Thank you, Pinkesh, for the kind words of introduction. And good evening, everyone. To Dr. Bansi Sabu and Team Diabetes India for invite. And after a very interesting session, we still have one more important talk, which is what should be priority in managing diabetes. And my concern is glucose. So I'm going to explain why glucose should be your priority in managing diabetes. So we've understood that diabetes is a major epidemic and it affects 537 million adults all over the world. It has a devastating health consequences, reduces the life expectancy by 5 to 20 years, increases the risk of other organ damages, and overall it costs a lot of economic cost. 35% of cost from loss of productivity is because of diabetes. So diabetes is a big burden to the nation. Now, to understand what is diabetes, I'm sure all of you don't need the introduction, but I'm telling this because to understand the importance of glucose. So, how is ADA defining diabetes? It is a group of metabolic disorder, carbohydrate metabolism, in which glucose is both underutilized as an energy source and overproduced due to inappropriate gluconeogenesis and glycogenolysis, resulting in hyperglycemia. So, it is a glucose fault which is leading to diabetes, right? Again, the diagnostic criteria, what it involves, it is the blood glucose levels. That is A1C more than 6.5, fasting more than 126, and postprandial more than 120. So these are the diagnostic criteria. Again, what it has, glucose values. Now, there are various types of diabetes: type 1, type 2, gestational diabetes, and other diabetes. Again, the classification has evolved over years now, trying to maintain the balance between insulin deficiency and insulin resistance. But overall, it is the glucose levels which are important, especially if you see managing type 1 as well as gestational diabetes. The most important factor you need to control is glucose. Now, why we want to control blood glucose levels is because of its complication, that is acute as well as chronic complications. So the acute complications are hyperglycemia symptoms, or there may be DK or HHNS or hypoglycemia. So in both the cases, of course, it requires an urgent management, and in that case, you have to control glucose whether it is hypo or hyper. The other problem is the chronic complications. It can be microvascular complications or macrovascular complications. And in order to prevent that, what is needed is again glucose control. So, how does glucose affect this? Basically, there are a cellular damage mechanisms, formation of advanced glycation end products, increasing in reactive oxidation ROS, PKC activation. Again, there are because of this cellular damage, pathophysiological effects are seen. Basically, it is endothelial dysfunction and inflammation which happens because of hyperglycemia, and there may be impaired cellular repair mechanism. So, all this, that is glycemic variability, whether it is hyperglycemia or hypoglycemia, will lead to oxidative stress, epigenetic changes, and inflammatory cytokines. In hypoglycemia, also, patient may have platelet activation dysfunction as well as inflammatory cytokines. So, both this will lead to endothelial dysfunction and damage, and therefore there will be micro as well as macrovascular complications. So when we are seeing diabetes complication, cardiovascular disease is one part, but there are microvascular complications like foot neuropathy, nephropathy, retinopathy, also the skin conditions. There is gastroparesis, there are dental problems. So in all these problems, also the most important factor which we need to control is blood glucose levels. Again, when we see patients with diabetes, what are we advising? So there is a frequent blood glucose monitoring which is needed. Why? Because it detects the glycemic variability. Sorry, it detects the glycemic variability and the hypoglycemia. It gives us information about the treatment changes and the effect of food intake as well as physical activity. So ultimately, even the long-term trials, they have shown that 1% reduction in A1C is very clinically relevant. The UKPDS have shown that each 1% reduction causes 37% risk reduction in microvascular complications and 14% risk reduction in MI. Again, the advanced have have shown that for difference of 0.8%, there is 14% relative risk reduction in microvascular events. So overall, all the trials have shown 1% A1C has good improvement in micro as well as macrovascular event. Again, the intensive control is significantly associated with decreased risk of cardiovascular event, and this effect is more relevant in patients with shorter duration of diabetes, that is less than 10 years, and no pre-existing cardiovascular disease. Evidence have shown that acute hyperglycemia, such as achieved after meal or during glucose variability and hypoglycemia, could contribute to legacy effect on some pathways related to the development of diabetic complications. So if the patient is delayed in achieving an A1C target, even if a newly diagnosed patient, if there is a time wasted in achieving a good glycemic control, there is increased risk of developing CV disease. So it is important to hit early, hit hard. The legacy effect, the metabolic memory is what we all know, and this is various studies like DCCT as well as EDIC have shown how intensive therapy compared to conventional therapy helps in reducing the microvascular complications. Again, they have shown that this intensive treatment, if we start early, the effect persists later on also. That is the metabolic memory, as we all know. So it is very important to understand that hit early, hit hard is how it has started over the years. We are managing diabetes from so many years. The question of other parameters arise now in last 2 decades because of newer drugs, but glucose remains the mainstay because it is there since so many years now. What does ADA 2025 recommend when you are saying adhering to glycemic goals? Again, the ADA goals are A1C less than 7, fasting between 80 to 130, and postprandial less than 180. So these are again the goals given by ADA for diabetic patients. So when we are managing diabetes patient, of course, this is our priority to get them to this. The glycemic assessment, as we discussed earlier, you can monitor the A1C or you can have a CGM. The what they recommend is time in range is what we want. Of course, along with that, we want to avoid hypo as well as hyperglycemia. And I'm trying to run fast so that the time can be covered up because of the plenary sessions which will be starting soon. So again, the ADA has given an individualized glycemic goal criteria. So when we are managing patients with diabetes, whether the duration of disease, the risk of hypoglycemia, the other diseases that are present, and the pharmacotherapy with cardiovascular, kidney, weight, and other benefits. So all this is what we have to consider and keep the goal accordingly. You may keep it less stringent depending on the individualization. Again, this is an ADA guideline and it recommends that glycemic control is one part. Depending on patients having CV risk, you can give importance to the drugs which are glucose lowering agents but will have a beneficial effect on the metabolic parameters and help in preventing or reducing ASCVD, CKD as well as heart failure. So again, I would say the same thing, even if the patient is admitted in hospitalized patient, persistent hyperglycemia, where it is sugar levels are more than 180, you have a goal of 40 to 80. Again, in patient with diabetes, the goal is blood glucose levels. So I would just say that individualized glycemic criteria, minimize hypoglycemia, hit early, hit hard, will have a short term as well as long term benefits to prevent the complications. So, if we see the glycemic control, it has various aspects. Early benefit, as you can see, good glycemic control reduces the mortality. It also emphasizes on targeting the overall cardiorenal risk management. Again, importance of multifactorial management has to be taken in consideration. So, I would like to end by saying the glycemic control should remain the central early therapeutic goal for patients with type 2 diabetes. I would say all diabetic patients implement multifactorial management and multidisciplinary approach, regular reviews, patient empowerment, and personalized interventions tailored to these disease heterogeneity is important. Thank you.